Good evening, friends. It is a pride and pleasure for all of us to meet you in this Saturday evening. We have a eminent galaxy of speakers from across the continent. We have Professor Parks, the president of the Royal College of Surgeons of Edinburgh, who's going to address us on the complications following a pancreatic resection. We have Professor Rachel Guest. She is a professor of HPV surgery at the University of Edinburgh. She's going to be part of our expert panel for the case discussion. We have Professor Chetan Kantaria, who is a professor and head of the surgical gastroenterology and liver transplantation at the State GS Medical College, Mumbai. We have two young dynamic surgeons, HPV surgeons, Dr. Diana and Dr. Govindraj, who's going to take us through a case capsule on the bleed management and the fistula management after pancreatic resection. Ladies and gentlemen, I have the honor of inviting our president, the Dr. L.P. Thangavelu of the Indian Association of Gastroenterologists and Endoscopic Surgeons to give the welcome address before we move to the academics. Over to you, President, sir.
Vanakkam, namaskar, good evening. I'm extremely happy and honored to be here today on this online program. And I am the president of Indian Association of Gastrointestinal Endosurgeons. IAGES, it is called IAGES. IAGES is founded in 1993 by Professor Udwadia and some of his friends. And now today it is one of the largest minimal access surgery association in the world with a life membership of 10,000. And our prestigious, I should tell as a president, I should tell something about IAGES. Our prestigious programs are fellowship programs. We are training more and more young surgeons in basic minimal access surgery and also in advanced surgery, minimal access surgery. So far we have trained and awarded fellowship 6,000 young surgeons all over the country. This year alone, we have conducted 13 basic surgery fellowship programs and 9 advanced laparoscopic, minimal access surgery, laparoscopic surgery programs. And we also give training in endoscopy, and we are awarding a fellowship. And more than this year alone, nearly 2,000 persons were trained. Apart from that, for young surgeons, for the beginners, we are conducting skill courses in cholecystectomy and laparoscopic cholecystectomy, and hernia surgery is becoming more and more popular. And we are conducting skill courses all over the country. India is a large country, and so we expert faculties will go place to place from different places and giving training to young surgeons. During COVID time, we did not stop our academic activities. That is how this prime time, IAGES, is a most sought after program in our country. And many expert surgeons, not only from India, all over the world, participated in this prime time program. And we have got international collaborations with various associations, IAGES and IPSIS, ELSA, and SAARC countries, minimal access surgery associations. And one more important international collaboration, ALSGBA, Association of Laparoscopic Surgeons of Great Britain and Ireland, And last year, a few months ago, I, along with my friends, we all came to Newcastle. At the time only, we have decided to invite Professor Rowan to our conference. I'm extremely happy that he has agreed to come over here in spite of his busy schedule. Thank you, Professor, and I'll tell something about the conference also. And through these international collaborations, we do exchange of faculties, and we send our young surgeons to other associations for training, and we have constituted several awards to encourage research and paper publication and postgraduate thesis. We are conducting every year a midterm conference. This year, the coming year in October, probably we are having an international, along with the College of Edinburgh, we are going to conduct an international conference. And this year in February 9, 10, 11, 12, we are having our National Congress. It is a landmark event in the history of IAGES. Every year in Tier 1 city or Tier 2 city, we select some important cities where lot of laparoscopic work is going on, and we conduct this program. So this year we are conducting in February 9, 10, 11, 12 at Great Avenue Codicia Trade Center at Coimbatore, southern part of India. In this conference, 200 national faculties, very popular, eminent national faculties are expected to participate. They already given their consent. 35 international faculties are participating. In this, all the 3 days, we are doing live surgery programs in the morning session, and all 4K transmissions. This time, the first time here in Coimbatore, we are doing these 4K transmissions, and we are having 5 orations, of which the most important oration is Professor Tempton Udwadia, our founder father. In his name, we have created oration, and for that only we have invited Professor Rowan, and he happily agreed. Thank you once again, Professor, and we are waiting for you to welcome you in Coimbatore. And apart from that, one more international faculty from UK, Neil Smart, he has agreed to deliver another important Krishna Rao oration. We are expecting 2,000 to 2,500 delegates in this Congress, the huge one. Already nearly 1,700 surgeons have registered for this conference. In this conference, we are arranging to keep 5 robotic systems for hands-on training to all the surgeons in all the 4 days, including the pre-Congress day. And we have got simulation in endoscopy and colonoscopy, and it's available for all young surgeons, beginners, and hands-on training arrangement for vascular suturing and stapler also arranged here. The interesting sessions, we are, the scientific session is shaped in such a way. There are a lot of interesting sessions about complications and challenges in the management of minimal access surgery by experts. It is very useful for youngsters. Apart from Coimbatore is a beautiful city, excellent climate in February. a lot of tourist places like Ooty, Kodaikanal, Siruvani, and many persons are fans of ISA Foundation, Sadhguru. He has agreed, Sadhguru has agreed to spend 2 hours on 11th evening. It's going to be a great festival, I think, our annual National Congress. Without taking much time, further time, I welcome all our guests. Professor Rowan Park, I thank you once again for agreeing to participate in and deliver the important oration. This year it is more important because the last month, 11th only, Professor Tempton Udwadia passed away. So in his options, you are going to deliver his oration. It's a very important event in the annual National Congress. And apart from, I welcome you. Once again, I welcome Professor Rachel, Diana, and Govindraj, and other great surgeons, Chetan Kataria. I welcome you all. I welcome you all to Coimbatore. I congratulate Professor Kanagavel for inviting so many eminent personalities for this program. Thank you, Kanagavel. Welcome you all. Thank you very much. Nandri.
Thank you, President. Thank you for inspiring us with what has been happening around the world of IAGES. Now, without much ado, we move to the next important agenda. Can I have the honor of inviting the National President, Dr. Satish Mida, to formally introduce Professor Parks? Over to you, Dr. Mida.
Oh, thank you, Dr. Kanagavel. From IAGES Secretariat and whole IAGES family, I invite you all for this prime time, and good evening to all. So it's an honor for me to introduce Professor Parks. Professor Rowan Parks is Professor of Surgical Sciences at the University of Edinburgh. He is currently President of Royal College of Surgeons of Edinburgh. His research interests are in clinical aspects of hepatobiliary and pancreatic disease. He continues to lecture extensively on these and related subjects. He also regularly reviews articles for a number of surgical journals and refers grants applications from funding awarding bodies. Professor Parks pursued his surgical training in Northern Ireland and was awarded Fellowship of Royal College of Surgeons in Ireland in 1993. He undertook a period of full-time research in the Department of Surgery, Queen's University, Belfast. This work investigated the effects of obstructive jaundice on the gut barrier function and resulted in the award of the Doctor of Medicine for him in 1997. His work investigated the effects of obstructive jaundice. Following this, he completed his higher surgical training in Northern Ireland and undertook a clinical fellowship in hepatobiliary pancreatic surgery and transplantation at Royal Infirmary in Edinburgh. He has been awarded completion certificate in surgical training in 1999, and the same year was appointed as senior lecturer in surgery and honorary consultant surgeon in Royal Infirmary in Edinburgh. He was subsequently promoted to reader in surgery in 2006 and was awarded a personal chair in 2010. Professor Park is the chairman of South East of Scotland Upper Gastrointestinal Cancer Group and various lead clinician for the Scottish National Management Clinical Network for Hepatobiliary and Pancreatic Cancer from 2005 to 2010. Professor Parks contributes significantly to postgraduate education. He has been training program director and chair of the Regional Surgical Training Committee and acted as regional educational advisor in Southeast of Scotland from 2006 to 2008. He was associate postgraduate dean in the Southeast of Scotland, chairman of Scottish Specialty Training Board for Surgical Specialties from 2009 to 12, and Deputy Medical Director of NHS Education from 2012 till last year, 2022. So we welcome Professor Parks deliver his deliberations on very important topic of perioperative complications following pancreatic surgery and the management strategies of it. Over to you, Professor Parks.
Thank you, Dr. Mehta. Ladies and gentlemen, I have an interesting fact about Professor Parks. His father happens to be a past president of Royal College of Surgeons of Ireland. Am I right, sir? And
right.
I think this is the first father-son duo who hold the highest office of the Royal College of Surgeons across the various societies of Royal Societies at the United Kingdom. It's been a pleasure to know that fact, sir. We look forward to hear from you.
It looks that in United Kingdom, there is a league, airship is there, and like that in Royal College of Edinburgh, father, son, grandson, all are going to become presidents.
Well, thank you very much indeed, Dr. Mehta, for those very kind, generous words. Yeah, it's quite an introduction. So thank you, and to Dr. Kanakapel and Thangvalu. It's a real pleasure to be joining you this evening. I'm going to try and share my screen. Hopefully, you should be able to see that. Can someone just confirm that that's okay? Thank you. That's great.
It's okay.
So it's my huge privilege to join my colleagues, Rachel Guest, Diana Wu, and to contribute to your IAGES prime time. I've heard a lot about it, a phenomenal webinar series that you run. And yeah, I'm delighted to be coming out to your national conference next month and really looking forward to joining you all then. It's a real honor for me to be joining you on that occasion and delivering the oration. But I'm also looking forward later in the year to welcome IAGES to the Royal College of Surgeons in Edinburgh for your mid-year meeting, overseas meeting. And we really would encourage you to travel and to come and enjoy the warm hospitality in Edinburgh. So it's lovely to be contributing this evening to this discussion. The management of complications following pancreatic surgery. There are a number of key complications that I think it's worth just exploring. The most well recognized probably is pancreatic fistula, but there are others that can cause significant morbidity and indeed mortality. That includes sepsis, often as a result of pancreatic fistula, hemorrhage, delayed gastric emptying, and then other medical complications. Now, the impact of complications after any surgery can be quite significant, but after pancreatic surgery, it can be very serious. Not only will it increase the length of stay, it'll increase the cost of managing patients. It often leads to significant functional impairment for the patient and a delayed return to normal level of activities. And for those patients that require adjuvant chemotherapy or to continue neoadjuvant therapy, that can be significantly impacted in patients who develop complications. This is just to give you some context, our own data over a prolonged period. It is a couple of years old now, but I think it tells a story. Just shy of 800 patients, median age of patients in their early 60s. Over that 20-year period, the median length of stay was 12 days. That's now well down. It's 10 days now in our recent series. But we've got good follow-up on these patients. And this particular study looked at a median follow-up period of 8 years. Now, when we want to set some benchmarks, we look at, well, what's published in the literature. And this is just taken from a publication from the Johns Hopkins Hospital, just showing that in their series, probably one of the biggest centers in the world, a perioperative mortality of over 2% and a morbidity rate of 30%. And this is in the era of John Cameron when he was chief of surgery at Johns Hopkins Hospital. And our own data is not dissimilar to that. So we feel that over those 20, 30 years that we've been running the HPB unit in Edinburgh, our 30-day mortality is just under 2.5%, slightly higher, obviously, at 90 days, 3.4%, and our 1 year mortality of just shy of 12%, and very consistent with other findings and reports in the literature. But what we're interested in is the morbidity that may lead to some of the mortality. And that's predominantly around pancreatic, postoperative pancreatic fistula, postoperative pancreatic hemorrhage, and delayed gastric emptying. And you can see the number of patients in our series that have had these, and we'll go into this in a little bit more detail. So what about pancreatic leak, pancreatic fistula? It's a definition being leakage of amylase-rich fluid, usually from the transection margin of the gland or from the pancreatic enteric anastomosis. In the literature, it's reported to occur in anywhere from the very rare but occasional publication with 0% pancreatic leak up to 30%. But it is associated with a mortality. And, you can see the figures there, 0 to 5% in those who get a pancreatic leak. The first definition of pancreatic fistula by the ISGPF was in 2006 and 2005. And you can see that they classified postoperative pancreatic fistula into grades A, B, and C. And they had various parameters for that, so that there was some consistency in reporting of the seriousness of pancreatic fistulas. But that information was updated and a revised definition published in 2016. And essentially, postoperative pancreatic fistula is defined as any drain output, no matter what volume, with an amylase content 3 times that of the serum amylase and any relevant clinical developments. Now, grade A is known essentially as a biochemical leak and has no significant clinical impact, whereas grade B results in a change in management where drains are left in situ for more than 3 weeks or require repositioning because of ongoing leak. And grade C, where patients either have required reoperation, they have organ failure, or mortality is associated with the fistula. So that is the new definitions, the current definitions from ISGPF. So if we look overall at the sort of prevalence of a biochemical leak, or what would be termed a grade A, it's much more common, but it rarely causes any significant harm. It usually settles spontaneously. It's only when you get into grade B and grade C that the risks to the patient increase. With grade B, it's generally manageable. The patient recovers, and therefore mortality is still relatively rare. Those, however, that fall into the grade C category should be less than 2% of patients fall into that category, but there's still a very high risk of either reoperation or mortality. And it's this group that we need to be most concerned about. So when we look at our own data over that sort of 20-year period, you can see about 30% of our patients had a definition of fit with a pancreatic leak, but the vast majority of those, 18% of the total patients, it was a grade A, a biochemical or a non-significant leak. Similar to the literature, those who had a grade C leak, it was around 2-3%, 20 patients out of almost 800. So that's important because postoperative management and the care of patients who develop complications is really what will determine and have a significant influence on their outcome. And those with a biochemical leak you would anticipate would have an otherwise uneventful recovery. Those with a grade B pancreatic leak may have some impairment, they may have some delay of functional return, they may have a prolonged stay in hospital, But with careful and good management, most, if not all of those patients should be expected to recover and return to a normal state of health. And as we've said, it's those that develop grade C leaks that we need to really focus on, because with rescue therapy, and that's really important for major pancreatic surgery, with rescue interventions, what you're aiming for is recovery rather than progressive organ failure and risk of mortality. So in the literature, what are the risk factors for postoperative pancreatic fistula? There's been a lot published about the setting in which the surgery is done, and particularly around hospital volume. Pancreatic reconstruction, is there a difference in the way we reconstruct after the resection using pancreatic jejunostomy or a pancreatic gastrostomy? We'll look at the literature. What about other patient-related factors? The blood supply or the perfusion of the pancreatic remnant, the actual texture of the pancreatic gland and the size of the duct. These are important things to consider. The use of patches and sealants, and the place, if you like, of pharmacological interventions. So there's 7 Ps for you to consider when you're looking at postoperative pancreatic fistula. Berkmeyer was the first to publish about the relationship of hospital volume to outcome after major surgery. And he looked at a number of different major operations, and this was the data for pancreatic resection. And you can see the reduced mortality rate associated with a progressively increasing number of procedures per year. This was published now over 20 years ago, and I think most in the literature now, most publications were just saying a high volume center would even be more than 16. It should probably be in the region of 20, 25 or even higher. So you can see even the dramatic difference when this publication came out of even changes between 1 and 2, 3 and 5 and 6 and 16. Whereas I think now high volume centers, we're talking we need to be doing 25, 30 or more procedures at least per year. What about an individual surgeon differences and outcomes with relation to postoperative pancreatic fistula? And I think that's where it's more difficult, and data is more difficult to determine. Most of the literature is published around the institution and the hospital volume. But that relates and is felt to be most implicated by how good postoperative morbidity and complications are managed. And it's this failure to rescue that is most important in defining outcomes. And that includes patients who get grade C postoperative pancreatic fistula. What about the difference reconstruction makes? Well, this was a publication from about 50 years ago or more, which described and documented all the different types of reconstruction. I think there's about 70 odd different ways of joining everything up after you do a Whipple pancreatic duodenectomy. So there are various ways, and there's a lot that has been published about these, comparing them, particularly the option between a pancreatic jejunostomy and a pancreatic gastrostomy. And there's been several meta-analyses of all those published results, and they, in summary, have slightly favored pancreatic gastrostomy, reducing the risk of postoperative pancreatic fistula when compared to pancreatic jejunostomy. However, it may come at the expense of a slightly increased risk of bleeding. So I think it's fair to say that the jury is out. The biggest international survey of common practice is that still 90% of surgeons worldwide use a pancreatic jejunostomy. So I think the lesson is that you do what you're comfortable, what you've been trained to do, and what you feel is most appropriate, and do it consistently. And that is probably more important than chopping and changing or one method over another. In Edinburgh, we do pancreatic jejunostomy. More often than not, we'll do a classical Whipple rather than a pylorus preserving, mostly a single layer pancreatic jejunostomy, and we do not use a pancreatic ductal stent. What about patient-related factors? Well, again, there's a whole range of factors that may be related to age, but age insofar as it usually reflects their cardiac and cardiovascular status. Comorbidities will impact on the risk and particularly cardiopulmonary impairment. Smoking is a risk factor for postoperative pancreatic fistula, as is obesity and sarcopenia. And therefore, the nutrition status of patients is very important to consider in optimizing good patient care. The arterial supply of the pancreas is also worth considering, and perfusion of the gland, because the neck of the pancreas is where you'll do your anastomosis, but that is actually the site where there is vascular anastomosis between the blood supply to the head of the pancreas and the blood supply to the body and tail of the pancreas. And therefore, potentially it's an area where blood supply to the resected margin may be compromised. There are other reasons for lack of good perfusion of the pancreas, and that could be due to significant intraoperative blood loss and hyperperfusion, or particularly postoperatively where there's a reduced cardiac reserve, hypoperfusion in the postoperative period. So the arterial supply of the pancreas is worth considering because it's at the neck where there is, if you like, arterial anastomosis and a junction between what is supplying, as I noted, the head of the pancreas or indeed the body and tail of the pancreas. And what Steve Strasberg in one of his publications now published quite some time ago was that if you transect the neck of the pancreas and you don't get adequate bleeding, you should take a further portion of the body of the pancreas and work back until you get good bleeding from the transected margin of the pancreas. So something to consider. The gland texture has been reported in numerous publications. A soft gland increases the risk of a fistula, as does a small pancreatic duct. And again, that is well recognized and should be taken into consideration when considering your operative technique. Now, there's been a lot written about ways to try and reduce and minimize the risk of a leak. Use of Tacosil wrapping or using sealants, or even indeed occluding the pancreatic duct. And there's been a number of small randomized controlled trials and systematic reviews looking at these various techniques, but overall showing that there's no significant benefit in reducing the risk of a fistula. There's been also a lot of studies looking at pharmacological intervention. And here the data is a bit more conflicting, with some studies showing a good effects, others not so much. Generally, what we could say is that in patients undergoing a distal pancreatectomy, there may be some benefit in pharmacological strategies, particularly if there's a high risk in patients with high risk. And that could go back to patients who have a soft pancreas or a very small pancreatic duct. But there's no benefit in low risk patients. I think that's a summary of the various trials. Octreotide would be the most common pharmacological agent given, and a Cochrane review looking at 21 randomized controlled trials and over 2,000 patients. What they showed was that octreotide resulted, if given routinely, in reduction in overall postoperative pancreatic fistula rates. But that was in all comers. And if you actually only looked at those who had clinically relevant pancreatic fistulas, there was no difference. So in other words, the patients who were the most benefit were those with a grade A biochemical leak, where it was really insignificant. And octreotide had absolutely no influence in those that got the more significant and serious and clinically relevant fistulas. The one study that has shown a benefit came out of Memorial Sloan Kettering, was the use of pancreatide. And they did show a significant reduction in clinically relevant postoperative pancreatic fistulas with routine administration of this agent. However, in that study, they didn't use standard definitions, the ISGPF definitions of postoperative pancreatic fistula, and their control group or their placebo group had a slightly higher than expected postoperative pancreatic fistula rate. And compared to other publications at the time, it was probably higher than one would have expected in their control group. And interestingly, no other center has been able to validate their findings with the use of this drug. So how do we diagnose the postoperative pancreatic fistula? Well, it might be a hydrogen fluid amylase. That might be very useful, but we also need to do some radiological imaging. And a simple way, if there's a drain in situ, is to do a tubogram and look for a communication to the pancreatic duct, and also doing cross-sectional imaging to look for collections and sources of sepsis associated with the leak. The management is generally to put the patient nil by mouth and to consider enteral or parenteral feeding, but a nasojejunal feeding tube, if possible, should be cited. Antibiotics should be given, and at this stage, it may be helpful to consider octreotide. And then the key is, do you let things settle down, or do you consider reoperation? The indication for re-exploration is when the patient's clinical condition is deteriorating, where they have either signs of peritonitis, generalized peritonitis, or worsening sepsis, or worsening organ dysfunction and organ failure. And it's these decisions, and in this group of patients in the postoperative period, that it is most important to make good judgment and make the right decisions. And it's around this area of decision making that is felt to make a difference in terms of recovery or not. And rescue therapy and appropriate intervention is really important. Making sure any collections, abscesses or fistulas are fully drained, and if not, then it might be an indication to go back to theatre as well. If you do take a patient back to theatre, what are the surgical options? One, it might be just to get good drainage, get drainage close and well around the site of the anastomosis and get a controlled external fistula. There are bridging techniques described in the literature. There's also some institutions and centers who have tried refashioning the anastomosis in the postoperative period, or changing what was a pancreaticojejunostomy to a pancreaticogastrostomy, or the fourth option being a completion pancreatectomy. And some of these will vary depending on the case and the expertise in the unit. In our own unit, we would generally focus on either the first of these, if it's a minor disruption of the anastomosis, to just get good drainage and to leave the remnant pancreas in situ and just get a very good controlled external fistula with good placement of multiple drains. If the whole anastomosis is disrupted, it may be worth then considering completion pancreatectomy. What has been described, and it is nice to see the drawings, but in practice, this is not really what it looks like. But this is the use of either an external stent or an internal stent, bridging between the pancreatic duct and the lumen of the jejunum. So this is in diagrammatic form what is described and what some people have attempted, but really it's not felt in our practice to be entirely helpful. And we would either just leave drains in the region of the anastomosis or else a completion pancreatectomy. So moving on quickly to other complications, postoperative or post-pancreatic hemorrhage, the incidence in the literature, 3 to 13%, but this is associated with a much higher mortality rate. The risk of a bleeding complication can often not only manifest as a dire emergency with collapse of the patient, but is also usually associated with underlying sepsis and organ dysfunction, if not organ failure, and a much higher mortality rate. Again, similar to the fistula, IAGES have classified postoperative pancreatic hemorrhage into grade A, grade B, and grade C. And you can see that that's related to the time of the onset, the location, whether it's intra or extraluminal, so whether it's a bleed into the gastrointestinal tract or into the abdominal cavity, and the clinical impact of the bleeding, whether there's hemodynamic compromise, hypertension, collapse, etc. So grade A, grade B, or grade C. Looking at our own Edinburgh data, again, 59 out of approximately 800 patients, grade B and grade C being the most severe ones. So 11 of our patients had a grade C, a very significant and serious postoperative hemorrhage, but that's over about a 20-year period. The management of early and late postoperative pancreatic hemorrhage, well, if it's early, it's usually due to a technical factor, and if severe, which most of them will be, that's the patient that needs, in general, to go back for a relaparotomy. Those that develop a late postoperative pancreatic hemorrhage, more likely than not, it will be related to pancreatic fistula, sepsis. There's usually then a pseudoaneurysm formation, but it may be due to an anastomotic ulceration. So these are usually delayed or late presentation of a hemorrhage. So what do? Well, it very much depends on rapidly assessing, evaluating the patient and looking at their hemodynamic status. Making some evaluation, whether it's been an intraluminal bleed that might be manifested by hematemesis, or whether it's extraluminal. If you have drains inside you, well, there might be blood that clears in the drains, but more often than not, they will either block, clot, or it'll be some other hemodynamic change in their vital signs, with or without peritonism and a change in their general status. So in the rare option where it's thought to be an anastomotic ulcer or intraluminal bleeding, you might need to consider endoscopy to look at that area, or at an ulcer, duodenal ulcer type picture. But the important thing is probably, if the patient's stable enough, to try and get a CT angiogram to look for the source of the bleeding. And here you can see a typical pseudoaneurysm bleed highlighted on the CT scan. What you do next might depend again on the stability or not, hemodynamic stability of the patient, and whether they'd be suitable to go to the radiology department for further angiography, and that might allow therapeutic intervention. It may not be possible if the patient's not stable, and they may require to go straight to theatre to try and get control of the hemorrhage, so reoperation. Here's an example of a patient who was suitable to go to the radiology suite, had a pseudoaneurysm from the stump of the gastroduodenal artery. And in this situation, a stent, an intraluminal stent, was deployed, a covered expandable metal stent, and you can see it across the site of the bleeding, controlling the bleeding and maintaining blood supply to the liver in this case. Here's another example of a pseudoaneurysm of the splenic artery, and in this case, the patient required embolization of the splenic artery to control the bleeding. Other complications associated with pancreatic resection, delayed gastric emptying, much more common, an incidence of 6 up to 50% reported in the literature, with the grading by the IAGES of, again, grade A, grade B, or grade C. And you can see the different interventions required or the length of time that the delayed gastric emptying lasted for. Again, our data from Edinburgh, 146 of the 770 odd patients. Most of those fell into the grade B category, so resulting in a delayed return to oral nutrition and usually a delayed stay in hospital or a prolonged stay in hospital. What can be done to try and prevent it? Well, it's difficult because often delayed gastric emptying is multifactorial. In the literature, it's suggested there may be a decrease in plasma motilin following duodenal resection, loss of vagal innervation to the pylorus and antrum, relative devascularization part of the stomach due to the extended lymphadenopathy, or it may be due to a collection or other postoperative complication resulting in delayed gastric emptying. Patience is probably the most important aspect of managing patients with delayed gastric emptying, keeping them nil by mouth, keeping them decompressed using a nasogastric tube, but considering how to continue their nutrition. And we will often use a double lumen tube where there's a nasogastric component, but also a nasojejunal extension to allow enteral feeding. But if that's not feasible, TPN. It's important to rule out some other complications. So cross-sectional imaging, CT, to exclude an intra-abdominal collection or fistula is important. And then waiting. The use of pro-motility agents can be considered. Metoclopramide would be the most commonly reported. Erythromycin has been reported as probably showing the most beneficial, with a 37% reduction in incidence in one study from Johns Hopkins. So that are your two options to consider in terms of pharmacological intervention. Other medical complications, lastly, current 4 to 19% of patients. They can be a wide range of patients, often reflecting the age of presentation that people will be having Whipple pancreatic duodenectomy. So cardiac, cardiovascular accidents, chest infection, pneumonia, DVT, PEs, and renal dysfunction. So in summary, pancreatic surgery, particularly proximal pancreatic surgery, Whipple pancreatic duodenectomy, is associated with significant morbidity, even in expert centers. Most of the reports in the literature would estimate that as 30 to 50% of patients will develop a complication. And that's important when we're consenting patients and advising them of the complexity of the surgery and indeed the risk of the surgery. The important bit is the careful perioperative, optimizing the preoperative care, but particularly monitoring the patients closely in the postoperative period and early recognition of complications. If patients are not making a straightforward or satisfactory recovery, they should be promptly investigated, and rescue therapy is probably what will determine most the outcome for the patient. Our interventional radiologists are critical in managing these patients and in providing not only the diagnostic, but therapeutic interventions. And we have to judge and make critical judgments regarding the right timing and the right approach to surgical re-exploration and definitive management. So thank you very much indeed.
Thank you, Professor Parks. It was like a gem. Every slide had very clear messages, and it looks we have clarity on how to manage the pancreatic resections. Professor Parks, I'm happy to introduce you, Professor Rajesh Bhojwani. He himself is a surgical gastroenterologist and a very busy pancreatic surgeon as well. And Dr. Rajesh, would you like to have some comments before we move on to the case capsules as such?
Well, good evening, everyone. Good evening, Professor. And my apology for joining slightly late. That was a very, very comprehensive coverage of the pancreatic complications. And I'm sure the postgraduates have been benefited the most. And I think that could cover each and every aspect. And I believe the discussion will be more fruitful during the case capsules. I think we can move forward here.
And before that, I want to make my comments. It's such a complex and complicated topic. You made it so simple, and even the beginners, young surgeons can understand it very easily. We are all very much impressed, Professor Park, and I could see how your presentation is going to be in our annual National Congress. Yes, we have selected a right person for that oration, and I am very happy.
Thank you very much, Freika.
Kanakvel, sir, could I ask one query?
Most, sir. Most welcome. Please go ahead, Professor.
Professor, very lucid presentation. I just wanted a clarification. There are some suggestions, literature suggesting that diabetes per se gives protection to POPA. What is your take on this?
Diabetes gives protection. What was the last bit? Sorry.
It gives protection to POPF, postoperative pancreatic fistula. There are some literature evidence suggesting that if the blood sugar is more than 108, then there are less incidents of POPF.
Yeah, I think there are occasional reports such as that. I think in general, but the risks of running very high blood sugars for other aspects of patient care can outweigh the benefits that you might show in one area, such as pancreatic fistula formation. I think fistula formation is much more influenced by the pancreatic texture, by the size of the duct, and by technical considerations. Smoking is known to be a significant factor, and again, that's due to the blood supply. So I think these are probably more important things.
Right.
Now, that would be my view.
The authors have postulated that because of the diabetes, the texture, there is more fibrosis of the parenchyma, and that is why it protects the fistula.
Yeah. And that might be true. And I think this goes to, it's such a complex area, because often patients who have a biliary stent in because they've presented with obstructive jaundice also have a bit of inflammation and fibrosis of the pancreas and a little bit of duct dilation even after a stent goes in. And that might help. And yet we also know that having a stent in leads to increased bacteriobilia and complications. So it's weighing these things up on what are benefits. But I think, yes, fibrosis and a firm pancreas is one of the factors that hopefully reduces the risk of a fistula. But we have to take each patient as an individual. And those that are diabetic still require careful management of their diabetic condition, as well as optimizing their physical condition for surgery.
Another query is that many people say that DG, delayed gastric emptying, is a surrogate marker of a small leak.
Yeah, I think that's a very useful rule of thumb to at least have in your mind. And if patients have delayed gastric emptying, it's one of the simple things to rule out. So they mightn't yet have manifested a temperature. They may or may not have a mildly elevated inflammatory markers, their blood tests, but but I think in those situations, it's worth getting some cross-sectional imaging and looking for a collection, a small collection, because that might be a very early sign of a leak, and that's good to know about. So I would have a relatively low threshold for getting a CT scan in someone who has delayed gastric emptying.
Thank you, Professor.
Thank you.
Now I request all the faculty, including Professor Parks, to stay with us for the panel discussion on the case capsule. Ladies and gentlemen, we have the honor of introducing Professor Chetan Kantaria. He is a very eminent transplant surgeon, and he has a very busy surgical gastroenterology practice, being a pioneering medical institution in that part of the country. The KM Hospital and the St. GS Medical College is revered for, I would say it is more than 100 years now to have the college running, and they have a very busy operating list as well. And personally, he has a huge collection of hepatobiliary resections to his credit as well.
Thank you, sir.
And he serves as the secretary of the Indian Hepatobiliary Pancreatic Association as well. And he's quite active in multiple academic bodies. And then the president of the IAGES and the IAGES fraternity. And when we requested Professor Parks, let us have a gender neutral meeting, Professor Parks did not have a bit of hesitation, and he said, yes, I have a right person for us. And that's where we got to know Professor Rachel Guest. And I should put on record, the entire arrangement has been done fantastically well by Professor Parks and his team to bring in Professor Rachel and Dr. Diana. Ladies and gentlemen, I also have the honor of introducing Professor Guest. Professor Guest herself is a pioneering hepatobiliary pancreatic surgeon, and she doubles up as a regenerative researcher as well. And in fact, she has got a PhD in the regenerative and stem cell research on hepatobiliary cancers. And to be precise, she is doing a lot of work on the CDH molecule on cholangiocarcinoma progression as well as the hepatocellular carcinoma progression. And she is a very active person in promoting the young ones, whoever achieves, whoever joins. We could see her Twitter handles and Insta. It's been flooded with a lot of recognition and confidence boosting methods. It is really nice for someone, a brilliant academician, to any small achievement of a youngster is highlighted and a very big cheer is seen in the social media. And I'm sure Diana is going to be highlighting and keeping us enthralled with the case presentations. So let us have like this, ladies and gentlemen. We have 2 cases. Let us have 20 minutes each for the each case, and let the senior registrars present the case. And I would recommend all the top hepatobiliary pancreatic surgeons to give their comments or give their opinions. I would also say at the end, maybe I will request each one of you take 1 minute of their time regarding how we are progressing on the various issues and what are the potential upcoming developments the world is looking upon. So this is the way I would like to handle this program. And Diana, we look forward for listening to you, and the stage is yours. All the very best to you.
Thank you very much. I'll just share my screen. Does that seem to be working okay?
Perfectly okay. Can you make it? Yeah, perfect. Good to go.
Great. And is my slide moving forward?
Yes.
Yeah, great. Thank you very much for inviting me to present today. My name is Diana Wu. I'm one of the registrars in HPB and transplant surgery at the Royal Infirmary of Edinburgh. And today I'm going to present a case of postoperative bleeding following Whipple's pancreatic duodenectomy. So just to give you some background about the patient, so this was a 68-year-old female who actually presented to our hospital as an emergency with a 3-day history of abdominal pain, nausea, and vomiting. She was normally fit and well with no previous comorbidities or surgery. She didn't take any regular medications. She was a non-smoker. She only took minimal alcohol. She had no family history of note, and she was retired, but she was fully independent and lived at home with her husband. So her initial blood results showed raised inflammatory markers and deranged liver function tests. And so she was started on antibiotics, and she underwent an abdominal ultrasound scan and an MRCP for investigation of suspected gallstone disease. And these investigations did indeed show signs of acute calculus cholecystitis as well as choledocholitis. And a CT scan of her chest, abdomen, and pelvis demonstrated the double duct sign, which you can see here. And however, there was no obvious pancreatic mass and no evidence of malignancy elsewhere on the scan. So it was possibly a bit unexpected when she went on to have an ERCP, which demonstrated a large bulging ampullary mass with an ulcerated center. Endoscopic ultrasound showed that this mass was in keeping with a neuroendocrine tumor and at the ampulla, and biopsies confirmed that indeed this was a well-differentiated neuroendocrine tumor. CT PET excluded any distant metastases, and the patient's case was discussed at our HPB multidisciplinary team meeting, where it was recommended that the patient could either undergo a Whipple's procedure to remove the tumor or conservative treatment with surveillance to track any growth in the tumor. So after discussion with the patient about the pros and cons of each of the management options, she decided to go ahead with the Whipple's procedure. So the patient underwent elective Whipple's pancreatic duodenectomy with a bilateral subcostal incision. No metastatic disease was seen on laparotomy, and the lesion was palpable at the ampulla as expected, and so the procedure went ahead. The gallbladder was noted to be very thick-walled, despite having completed a course of antibiotics prior to the operation. And the operation note mentions that the surgeon had been planning on resecting the gallbladder en bloc with the rest of the specimen, but that this was not possible, and therefore cholecystectomy was performed separately. So this could suggest that there was potentially a lot of inflammation in this area, making the dissection more difficult than normal. The rest of the operation was uneventful, and a 28 French drain was placed, and the estimated total blood loss was 800 mils. The patient was admitted to the high dependency unit postoperatively at around 4:30, and at this point she was noted to be stable with spontaneous ventilation, oxygen saturations of 99% on just 2 litres of oxygen. She was noted to be peripherally cool, but she had a heart rate of 85, sinus rhythm, and she was requiring 3 mils per hour of noradrenaline to maintain a systolic blood pressure of 95. And it was reassuring that she was passing clear urine. She was alert with the GCS of 15, and her epidural was working well. Her abdomen was soft, and there was only a minimal amount of hemoserous fluid in the abdominal drain, and she was apyrexial. The patient was then re-reviewed just over an hour later at around 17:40. And at that time, things had changed dramatically. So the patient was complaining of lightheadedness. She looked very pale. She had very cool peripheries. She'd become tachypneic and tachycardic at 130 beats per minute. And there'd been a rapid increase in the noradrenaline requirement. So from 3 mils an hour to 30 mils an hour in order to maintain a systolic blood pressure of 85. Her urine output had also dropped, and her blood pressure was noted to be significantly fluid responsive. She was less alert with a GCS of 14. Her abdomen had become tender, and there was some strike through of blood on the dressing, and it was noted that there was around 100 mils of fresh blood in the drain. So an arterial blood gas was performed, and this showed a drop in her hemoglobin level from 107 to 56. Her lactate was 2.6. So all the physiological signs were pointing towards postoperative bleeding. The ICU consultant and the surgical consultant was contacted immediately, and the major hemorrhage protocol was activated, and 4 units of red blood cells and 4 units of fresh frozen plasma were requested and commenced whilst the patient was urgently transferred to theatre for relaparotomy. So here they found copious blood and clots in the abdomen with a total of 2.7 litres of blood loss. Intraoperative Rotem was used to guide further transfusion requirements throughout the operation, whilst the surgeons carefully performed 4-quadrant packing, inspection, and lavage. And they found a spurting arterial bleed coming from the cystic artery stump. So this was oversewn with a 4-row proline, with care taken not to occlude the right hepatic artery. No other sites of any hemorrhage were seen, and the anastomoses were all noted to be healthy and intact. All the packs were removed, and a 28 French drain was placed. So after this, the patient went back to the high dependency unit, and essentially she made a good recovery over the next 12 days. So by day 2, her blood pressure support had been weaned down. By day 3, she was stepped down to the ward, and she was able to commence a soft diet. By day 5, her abdominal drain was removed, and she was put onto oral analgesia. There was a small setback on day 10 where she had a urinary tract infection and urinary retention, which required recatheterization. But by day 12, she was able to be discharged home on Creon, a proton pump inhibitor, and 4 weeks of prophylactic low molecular weight heparin, which is what all patients undergoing major HPV resections for cancer receive in our unit. So if I'm remembering rightly from Prof. Parks' talk, 12 days is probably about average for this kind of resection anyways. So I think...
Please go
sorry.
ahead. No, please go ahead.
In this case, I think there were lots of things that were done really well, and it's a good example of excellent management of postoperative bleeding that prevented what could have been a fatal outcome. There was very prompt recognition that the patient had deteriorated, and she was assessed using a structured A to E approach. This allowed prompt recognition of the problem, which was correctly identified as intra-abdominal bleeding. She was given appropriate intravenous access with a central line and multiple peripheral cannulas, which enabled resuscitation. One thing that the team didn't do, which could have been considered, was to clamp the drain. This could have provided some tamponade whilst the patient was being transferred to theatre. There was good recognition that the patient had lost a large volume of blood and that the major hemorrhage protocol needed to be activated to get access to blood products quickly. I've put a question mark about tranexamic acid. It wasn't given in this case, but I know that it is increasingly being used in major hemorrhage, although I think most of the evidence is for use in trauma patients, but it's a potential discussion point. And there was very good early escalation to senior clinicians and a quick decision for relaparotomy. So overall, a very well-managed case of post-pancreatectomy bleeding. Here I've just included some information about our major hemorrhage protocol that we use in our hospital. So this should be activated when a patient has lost over 50% of their blood volume within 3 hours, or more than 150 mils of blood loss per minute. And by activating this protocol, we get immediate contact with blood bank to request blood products, a dedicated porter who can deliver products and samples, and if required, we can be connected to the on-call hematologist for advice. And depending on the situation, we can choose to request either O-negative blood, which we can receive immediately, group-specific blood within 15 minutes, or fully cross-matched blood within 35 minutes. And fresh frozen plasma and cryoprecipitate take around 20 minutes for thawing. So in our case, the patient ended up receiving a total of 4 units of red blood cells and 4 units of FFP very promptly, thanks to the major hemorrhage protocol. And finally, I'll just skip through some of these slides as Prof. Parks has already covered all of this very well. But so as we've said, post-pancreatectomy hemorrhage, or PPH, is thankfully one of the less common complications, with an incidence of less than 8%, but it has a very high risk of mortality of up to 38%. Often a small amount of bleeding in the abdominal drain or in the NG tube or melena can represent a so-called sentinel bleed, which can then be followed by massive hemorrhage. And so recognizing these sentinel bleeds and acting upon them promptly is crucial for preventing fatal outcomes. And this recent systematic review found that the most common site of bleeding is the gastroduodenal artery stump, followed by the common hepatic artery, the splenic artery, the SMA, and the proper hepatic. But there are many other sites of potential bleeding for post-pancreatectomy. So in addition to the major vessels in the area, bleeding can occur from the cut surface of the pancreas or from the suture lines of any of the anastomoses, the gallbladder fossa, the resection bed in the retroperitoneum, or of course from pseudoaneurysms that can develop secondary to pancreatic fistula or intra-abdominal abscesses. And again, as we've mentioned, the International Study Group of Pancreatic Surgery have developed an objective classification system in order to standardize the reporting of PPH. So in the system, PPH can be differentiated into early or late onset, where early onset is defined as within the first 24 hours post-op and is usually caused by a technical failure of hemostasis during the index operation or an underlying coagulopathy, or late onset defined as after 24 hours post-op and typically occurs as a result of other complications, as we've mentioned, such as erosion of a vessel secondary to a pancreatic fistula or ulceration at the site of anastomotic dehiscence, etc. PPH can also be defined by its location, which can be intraluminal or extraluminal, and finally it can be classified by severity according to the volume of blood loss, the drop in hemoglobin concentration, whether there was any clinical impairment of the patient, whether there was a need for blood transfusion, and the need for any invasive intervention. And in terms of management of PPH, 3 main options for intervention are endoscopy, interventional angiography such as coil embolization or stenting, and of course operative intervention. And the choice of intervention will of course depend on the timing, the location and the severity of the bleeding. And this paper by Wellner et al. has proposed a treatment algorithm which takes into account all of those factors, as well as whether a pancreatic fistula is also present. So if we take our case, for example, this was extraluminal bleeding, it was early onset, and so the suggested most appropriate first-line intervention is operative hemostasis. However, if it had been late onset or if it had been intraluminal associated with a postoperative pancreatic fistula, then interventional angiography is suggested as a better first-line treatment, with operative hemostasis suggested as a second-line treatment. Thank you very much for your attention, and I'm happy to take any questions.
That's a brilliant sharing of well-managed patient. Now I'd like to take the experts to take time off to give their comments. Can we start with Professor Rachel, ma'am? Over to you.
Yes, and thank you. And it is indeed a good example of the importance of the team and recognition of complications early. And I think that the key factor in this patient, not even having a prolonged length of stay, was that early recognition of complications. And although it's specialists who do these procedures, it's the juniors on the ward and the critical care staff who are looking after them post-operatively and who have to recognize these complications. And so much of the literature has shown that it's that early recognition that is really key to the good outcomes in pancreatic surgery. So I think it's a nice case to illustrate that sort of rescue situation. Sadly, most of our PPH complications we see are not so satisfying to sort out, and unfortunately occur, as Rowan has said, in the context of the leak and sepsis, and it becomes extremely difficult operatively to identify bleeding points and control hemorrhage operatively. And so again, it's the team and the interventional radiologists who become the key people to identify most PPHs, which would be in that sort of post 24-hour period. But yeah, very nice case, Diana. Well done.
Thank you.
Professor Parks.
Yeah, I think Rachel has summed that up very, very well. These patients and the patient in question that Diana presented, I guess, when she went off, it was in the early evening, so a lot of the daytime staff might be leaving, and that just shows the importance of picking these things up early and intervening quickly, and the patient ultimately had a good outcome. As Rachel has said, it'd be nice if all our postoperative pancreatic hemorrhage was like that. More commonly, it is going to be the later presentation. I think another important point that Diana mentioned too was that the sentinel bleed. Don't ignore that. So if someone has what is thought to be a minor bleed, there's a bit of blood appeared in the drain, but they're hemodynamically stable, they look well. There was perhaps a bit of blood in the vomitus, or just the patient isn't quite right. It's having a low threshold, I think, to investigate. And in that situation, if there was a herald bleed or a sentinel bleed, again, getting an early CT with angiogram, CT angiogram would be vitally important to try and look for the pseudoaneurysm that then may have a big bleed, and that's what you want to pick up before that big bleed happens. So the case presented was, maybe more straightforward, but emphasizes prompt intervention, taking the patient back to the theatre. I think the message about any bleeding episode, however trivial it might appear, it's the important message is consider it serious and investigate so that you know what you're potentially dealing with. Thank you.
Thank you, Professor Parks. Professor Kantaria.
This particular case is a good example of how early recognition and timely intervention leads to a good outcome. As far as the case per se is concerned, it was really unusual that it was the cystic artery bleed, maybe because of the slipping of the clip or ligature, whatever was applied. The thing which I was a little intrigued is that this patient was shifted on NORAD post-operatively. So maybe intraoperatively, her BP must have remained on a lower side, or there is a practice among certain group of anesthetists, especially when they are dealing with major cases, to electively start on NORAD, but however they taper it. So the very fact that this patient got shifted on NORAD, so that is one thing which is a matter of concern. And within 3 hours, the requirement of NORAD went up. So that is also another recognition of that there is something going wrong. And how without investigating, the patient was taken up for surgery is an excellent example of how you should do timely intervention without wasting time in investigating, because the patient was obviously bleeding. Excellent case presentation, Dr. Diana.
Thank you.
Professor Bojwani.
Yeah, very good evening, and thanks, Diana, for a very good presentation and a very well managed case in that kind of an emergency. However, I would also want to mention a few things. This is not like a typical post-pancreatic duodenectomy bleed. As you mentioned, the gallbladder was very thick. The CBD was studded up with stones. Obviously, the surgeon spent some difficult and a longer time doing the dissection there. Usually, the cystic artery is very easily and properly managed in patients wherein pancreatic duodenectomy is being done, because the gallbladder is usually distended and not thick-walled, as you mentioned. But obviously, the surgeon did a very good job trying to deal with that kind of gallbladder and the bile duct, which was studded with stones. And the biochemistry showed that the patient was running some active cholangitis. The CRP was high. The patient was in sepsis. These are the patients who are quite likely, or I would say they are more commonly likely to bleed from somewhere around the porta hepatis. But I must compliment the team which took good care of this patient and managed, and I must compliment the surgeon who managed the bleed after opening up the abdomen, because in such patients, and with that kind of super fast bleeding and massive bleeding, what you can call, what saved this patient was probably not the sentinel bleed or the bleed through the drain, which the clinicians picked up. It was the abdominal signs, the abdominal distension, which the clinicians picked up, which showed them that while it was only 100 ml in the drain, there was much more inside the abdomen, which was getting collected inside, and therefore there was this rapid escalation of noradrenaline. Now, having said that, in such situations, what is much more commendable is that the surgeon took care of the cystic artery while not compromising the right hepatic artery. Because in these patients, why bleeding happens is because during the initial surgery, the primary surgery, the cystic artery origin from the right hepatic artery could be so close that actually with this kind of rapid and enormous bleeding, it might actually could have been bleeding from the cystic artery stump from the right hepatic artery. And to be able to manage that kind of bleeding without compromising the right hepatic artery is certainly commendable. And that is why perhaps this patient did very well. And I must compliment that this patient was managed very well. Having said that, I would probably have thought twice before embarking on that decision to operate away directly with the Whipple's operation because of two things. A thick wall gallbladder, a patient with cholangitis with multiple stones in the CBD, and a small neuroendocrine tumor. We have not seen the cross-sectional imaging. On the endoscopic picture, it just appeared about 1 to 1.5 centimeters, maybe not 2 centimeters. I'm not sure whether it was a neuroendocrine tumor of the pancreas or the ampulla. But if it was less than 2 centimeters, I'm not sure if I had more information about the patient, I would have probably waited and cleared the CBD, took the gallbladder out, and perhaps carried out the pancreatic duodenectomy if it was indicated in the next stage, maybe after 6 to 8 weeks or 10 weeks. Thank you.
Would you like to comment about it, Dr. Diana?
Yeah, thank you for those interesting points. I know that there was a lot of discussion about the best way to move forward with the patient regarding the stones, and there was a lot of discussion with the patient about the pros and cons and potential for complications of this big Whipple's procedure versus clearing the duct and just doing surveillance for this neuroendocrine tumor, which was, I think, maximum 18 millimeters in diameter. But after extensive discussion, the patient herself was very keen that she wanted to just have this tumor removed and everything dealt with at the same time, and was willing to accept this risk of postoperative complications. And so it was really a patient choice in the end.
Yeah, I agree.
I have a quick question to all of you. Where exactly the radiological interventionists come in the scene? Do we, in this patient, I understand hemodynamic loss was quite rapid and the decisions have to be made. Is there a role for an interventional radiologist to have a quick angiogram, or should that be attempted at all?
I think in this patient, there is no question of involving the interventional radiologist, because her BP was rapidly coming down. Her requirements for NORAD was increasing. There was abdominal distension. So it was very obvious that wherever she was bleeding from, she was bleeding quite actively. And in this scenario, the best that a surgeon would do is straight away take to the OR and explore the patient.
There's more to it also. I absolutely agree with Dr. Gansari or Dr. Kanavale. But importantly, as we must understand, in a post-operative hemorrhage after pancreatic adenoidectomy, why we need angio is because we want to do minimum harm to the patient and at the same time, ensure no bleeding without disturbing those precarious anastomosis with the pancreas and the bile duct, because the anatomy becomes very complicated after that. And you will not be able to look at the SMA and the SMV and the left part of uncinate just in case, or the mesenteric root, unless you mobilize. And that tends to kind of, precariously, you tend to handle those precarious, viscera and the anastomosis, which you want to avoid. And at the same time, just precisely embolize the bleeding point. But here in this case, the bleeding was so massive and it was soon after the operation. So I think that was the right judgment, and kudos to the team. They did, I think, an excellent job.
Dr. Rachel or Dr. Pax would like to add something to it, or shall we move to the next case?
No, I would agree with everything that's been said. Within 24 hours, it's very likely that that's an operative issue that can be sorted out. And, without the leak there, it's likely that you'll be able to control that operatively. So we have a very low threshold for getting the radiologists involved, but this early after surgery, we would take them back to theatre.
I totally agree with what Rachel's just said. I think that is the key. I guess I want to maybe just lastly, before we finish, we'll go back to the point of the noradrenaline. So most of the vast majority of our patients having open surgery will have an epidural. And what our anaesthetists and anaesthetic team prefer not to do if blood pressure is running a little bit low because of the epidural is not fill them up with fluid. And so they would tend to use a little bit of noradrenaline as the patient goes back to the high dependency unit. So it's not routine, but it's not uncommon that they may well be on a little bit of noradrenaline rather than overfilling the patient with intravenous fluids. But it was that change in the requirement and the unstable nature of the patient and the requirement for both an increase in the inotrope support and fluids to maintain blood pressure that it was the indication for surgery as well as the clinical signs.
Points are well taken. I think we have to move to the next case in want of time. I have the honor of inviting Dr. Govindraj, the Senior Specialist Registrar from the Department of Surgical Gastroenterology and Liver Transplantation, KM Hospital. Dr. Govindraj, can we have your presentation now?
Sir, is my presentation visible? Yes, thank you, sir. Namaskar. I bring greetings from India and from my institute, IAGES Medical College and KM Hospital. I am Dr. Govinda Desai, MCH final year surgical gastroenterology resident in KM Hospital, Mumbai. I would take you all today through a case capsule of a patient of a pancreatic duodenectomy done for a distal cholangiocarcinoma. So a 67-year-old gentleman presented with history of upper abdominal pain since 2 months. It was dull aching. There was no relation to meals and it was non-radiating. Patient also gave history of yellowish discoloration of eyes and skin, indicating a progressive jaundice since last 2 months, associated with itching and passage of clay-colored stools. He also said he also gave history of loosening of clothes, suggestive of weight loss. However, there was no history of any fever. Patient is also known case of hypertension and diabetes mellitus when maintained on oral medication. So on clinical examination, patient was conscious oriented, had an ECOG status of 1. He was upright, he was vitally stable, and BMI was 28.4. On examination, patient had icterus, however, no other signs of liver cell failure. On per abdominal examination, it was soft, non-tender, bowel sounds were present, and gallbladder was not palpable. On PR was essentially common. So with this background, because of the age of the patient as well as short history, we drew a clinical impression of malignant obstructive jaundice and investigated the patient. The blood investigation suggested obstructive jaundice with the direct bilirubin to the tune of 12.1, and ALP was also rate 645, which was well above our normal reference rate. However, the patient did not have cholangitis as counts were normal, 7,200. We also evaluated the patient with tumor marker in the form of CA19-9, which was elevated. On screening ultrasonography of abdomen, gallbladder was mildly distended. There was dilated proximal and mid-CPD, and a maximum diameter measured on the ultrasonography was 1.6 cm, associated with central and peripheral intrahepatic biliary radical dilatation. Liver was normal, pancreas could not be commented upon, and there was no free fluid. Hence, as a next step, we undertook CCT abdomen with pancreatic protocol, and in the pancreatic phase, we could see circumferential enhancing distal CPD thickening, which was for a short segment of 1.7 cm, with a resultant proximal dilatation of the common bile duct and common hepatic duct and IHPR. Main pancreatic duct was 4.5 mm. There was no significant peripancreatic lymphadenopathy, and there was no other evidence of metastatic disease. So with this background and no evidence of cholangitis, we decided to take this patient for Whipple's pancreatic duodenectomy. Patient was counseled and so were the relative. They were informed about the intraoperative procedure as well as the postoperative complications and the postoperative course. Preoperative anesthetic detailed assessment was done. We also took help from our cardiology colleagues. On 2D echo, ejection fraction was 60%. Also, the endocrinology opinion was taken and patient's sugars were well controlled before taking the patient for OT. Patient underwent the classical Whipple's pancreatic duodenectomy. Intraoperative finding, there were no evidence of any metastasis on laparotomy. We usually take bilateral subcostal incisions in our institute. The distal CPD mass was palpable, which was around 2 by 2 cm. Common hepatic duct was dilated to the tune of 2 cm and pancreatic duct was around 4 mm. The pancreatic texture was soft. Also, hepatoduodenal ligament lymph nodes were noted, largest measuring 1.5 cm. However, there were no other retropancreatic or aortocable lymphadenopathy. Liver was normal, there was no free fluid. The estimated intraoperative blood loss was around 700 ml. And as a part of our institutional protocol, we gave somatostatic analog intraoperative. Immediate post-op, patient was extubated and was shifted to intensive care unit without any inotropic support. ABG was normal and lactates were to the tune of 2.8. Postoperative hemoglobin was 9.4. On postoperative day 1, patient was vitally stable, no oliguria, rise tube aspirate was around 55 ml bilious, and drain was serosanguinous 150 ml. Investigations, hemoglobin was 9.2, creatinine and electrolytes were normal. On post-op day 2, patient was stable. We were able to mobilize the patient and give chest and limb physiotherapy. However, the rise tube aspirate had increased to 250 cc. Although the drain remained serosanguinous and it was only 80 cc over the 24 hours. On post-op day 2, there was a decreasing trend in the drain output from 50 to 25 cc on day 3 and day 4. Patient was also started on NJ feeds on post-op day 3, and which was gradually stepped up. However, the alarming feature was the rise tube aspirate was persistently high, being 250 cc on post-op day 3 and post-op day 4, 310, suggestive of delayed gastric emptying, which could have been indicating to postoperative pancreatic fistula. Also, drain fluid amylase levels on post-op day 3 as a routine. We do not do the drain fluid amylase level on post-op day 3 as a routine protocol. Only if a suspected POPF is there, then only we would consider doing a drain fluid amylase in our institute. However, on post-op day 5, patient had a fever spike. Patient pulse was 94, BP was 110 by 74. Urine output was 1800, there was no oliguria. However, the drain was 250 cc and it was dark brown in color, suggestive of a classical sinister appearance. Although the per abdomen was soft and rise tube aspirate persistently remained high of 320 cc on post-op day 5. Because of all these factors pointing towards a clinical suspicion of postoperative pancreatic fistula, we assessed the drain fluid amylase and it was more than the 3 times of the institutional normal serum value. Also, on the routine investigations, total leukocyte count had risen to 21,200. So, we first assessed this patient with a bedside ultrasonography to rule out any intra-abdominal collection. As intra-abdominal collection was ruled out, decision was taken to manage this patient conservatively. In our institute, we usually continue broad-spectrum antibiotics up till post-op day 5, and usually on post-op day 5, we stop the dose, and somatostatin analogs are continued on the till post-op day 3. But because of the increased counts and the fever, broad-spectrum antibiotics were continued in this patient, although NJ feeds were also stepped up and continued. The drain fluid was sent for culture and injection octreotide somatostatic analogs were restarted. On post-op day 6, patient did not have any other fever spikes, no tachycardia, vitals were stable, and drain output, although it remained a dark brown in color, showed a mild decreasing trend to 180 cc per day. Again, the per abdomen was essentially soft and rise tube aspirate continued to remain on higher side. We were not able to remove rise tube in this patient, although we continued the patient on nasogenital feeding. We were lucky enough, and on post-op day 3, post-op day 7, 8, and 9, the drain output showed a decreasing trend, decreasing from 80 cc to 10 cc by the post-op day 9. Also, RT output decreased, and we were able to remove rise tube on post-op day 8. Counts had decreased to 7,200, and patient was also tolerating oral food diet. On post-op day 10, patient was vitally stable. Drain was 10 cc, and hence the decision was taken to remove the drain, and also injection and octreotide as well as the injectable antibiotics were stopped. On post-op day 11, after ensuring adequate oral intake, nasojejunal tube was removed and patient was discharged and advised to follow up with histopathological report. So this patient, according to ISTPF revised 2016 classification, classified this as type S grade B POPF Although in this patient, there was no persistent drainage, there was no endoscopic or percutaneous intervention done or angiographic procedure done, the patient showed a change from a normal clinical outcome in this patient. There was a clinical relevant change in the form of adding of antibiotic, increased hospital stay. The usual hospital stay is around 6.5 days for our patient. However, patient stayed for 11 days, which was more than the 2 standard deviations. Also, patient had evidence of infection without organ failure. So as there was no organ failure, no sepsis, no POPF related death, or no need for reoperation, patient was classified as grade B. Patient also had associated type A delayed gastric emptying, as we could remove the rice tube on postoperative and start chemo in the field. Thank you.
Thank you, Dr. Govindraj. I think it has definitely evoked up a few important issues which need to be addressed in the perioperative period. Now I request the panel to give their comments. Can we have from Parks and going down to the Indian colleagues?
Thank you, and thank you for a very nice case presentation, beautifully presented. So I think this, highlights very careful monitoring of a post-operative patient, both from with respect to their clinical condition, their vital signs, their blood parameters, and any appropriate investigations. So those daily monitoring, and I think that's critical in these high-risk patients, and monitoring of drain output, not only the volume, but also the consistency of it and the color of it. And that's really important. So there's clearly a change on day 5. And at that point, there was that one spike of temperature. The white cell count went up, the inflammatory marker was noted to be elevated, and there was a change in color as well as a slight change in volume of the drain output, which had prior to that been reducing. And I think, recognition of that is the number one learning point. That was recognized as a change. It was abnormal, and appropriately, patient was carefully assessed and investigated, and an ultrasound was done to look for any significant collections. And again, this may depend on the setting of whether and availability of other cross-sectional imaging. I guess in our own unit, we would probably elect to undertake a CT because of the slight risk that an ultrasound, which is very operator dependent, may not get as accurate a view, particularly around the pancreatic jejunal anastomosis. So it certainly exclude a large collection, and it might be a very useful screening radiological investigation. But one thing to consider, if things hadn't improved, would have been a very low threshold to get a CT scan. But I think otherwise, the other management options, such as continuing the antibiotics, continuing the enteral feeding, and commencing octreotide or restarting the octreotide, are all entirely appropriate. And that would be part of the package, if you like, of a conservative management. And pleasingly in this case, the volume of output from the drain got less. There was no further evidence of a temperature or a spiking temperature, because that would again be a worrisome feature. But the temperature settled, patient remained hemodynamically stable, and got to the point where it could be removed. So, this patient, as has been accurately presented, was a biochemical or a grade A leak, if you like, and had a good outcome. I guess the other things to consider, if that had not been it hadn't resolved like that, would be, yes, the CT scan. Another simple investigation, which is cheap, is to do a tubogram and, to do a dye test using water-soluble contrast down the tube to look and see if there is a communication, or indeed if there's a large collection associated with the anastomosis. It's another useful thing to have available. But the importance was the recognition and picking up the abnormality, appropriate conservative management, ongoing feeding, the use of octreotides and antibiotics, and determining how the patient was going to either get better, or if they hadn't, what else should have done next. So thank you.
Thank you, Professor Parks. Professor Rachel, I'd like to listen from you about this patient. And I'd also like to hear from you regarding the drain management protocols in your department.
Thank you. So one important learning point from this case, I think, is that these patients with the distal cholangiocarcinomas probably are higher risk of leak from the beginning. Those who haven't got chronic pancreatic ductal dilatation and soft pancreas, you should really be cautious of in terms of the leak. So for these patients in particular, our practice would be to do a routine day 3 drain amylase for them. And it's that key siting of the drain adjacent to the anastomosis at the time of surgery, which is really crucial, making sure you get your drains in a very good place. So we have a very low threshold to leave drains in until they're extremely low volume in this case. But I think the team should really be commended for adhering to the key principles of managing these patients, which were good enteral nutritional support and good control of sepsis. So excellent case for presentation. Thank you for that.
Diana, you would like to give your comments? Do you have anything to share?
Yeah, very good case presentation. As has already been mentioned, we I guess we would routinely do our day 3 amylase level check on the drains, as was done in this case, to give us an idea of whether there was a leak or not, and that helps you to pick these things up earlier and then manage them earlier as well. But yeah, no, nothing else to add from my side.
Professor Bojwani.
So I think it was another example of a very well managed case in a very specialized unit, which paid kind of attention to details and managed it every day, and brought the patient out very quickly and appropriately. Having said that, I would like to, one or two things, as very rightly pointed out by Professor Rowan Parks. And of course, by definition, it might fall into POPF type B. It behaved like type A. And normally, whenever, in my experience, whenever there is something like that, a kind of type B fistula, wherein you have some kind of discolored content to the tune of 50 to 100 ml on day 1, it would usually not stop in the next 2-3 days. Usually not. It will usually continue over, say, 7 to 10 days at least, and eventually turn purulent before you take the drain out when it becomes clear. So I think that was one good outcome which this patient showed. And I would also absolutely agree with Professor Rachel when she said that cholangiocarcinomas are not easy to handle with pancreatic duodenectomy because the pancreas is soft, not easy to handle. And this was also kind of reflected in the intraoperative findings that were managed. This patient lost about 700 ml of blood, which will not be usual in a specialized pancreatic unit. I'm sure the uncinate was bulky and vascular, and there was some contribution by this being a cholangiocarcinoma and not a carcinoma head of pancreas, where you might actually intend or might lose less blood, and it took about 5 hours. So I think there was a lot of learning there. And one, maybe just a matter of protocol, I would have probably wanted to know whether it was a classical pancreatic duodenectomy or a pylorus preserving. That is one. And is it a protocol to use the nasojejunal tube in every single patient after Whipple's in their unit? Because I'm sure there are very many variations across the units. We don't use either a feeding jejunostomy or a nasojejunal to begin with, only when indicated in a type B or a type C fistula, which will not be very common in a specialized unit, that we will then later put in a nasojejunal tube. So I think protocol-wise units differ, but overall a very well managed case, and congratulations to the team.
Thank you very much, sir. And before I ask Dr. Kantaria to give his final words to close the session, there have been a couple of questions from the forum. And one, Dr. Somil Vyas has asked us, in this case, if you have done a broad jejunostomy, does it could have helped us in reducing the delayed gastric emptying? And is there a role for that type of jejunal decompression, additional procedure when we do on Whipple? And if yes, what is it and when is it indicated? Anyone who would like to comment on this?
A personal view is, I think there are many other factors that are probably more relevant for delayed gastric emptying. And some of them you think you might have done the most technically beautiful anastomosis. There's nothing else that can contribute to this. And it's just that patient. So I honestly don't think any other surgical procedure or way of doing an anastomosis is the key issue. And again, as we mentioned earlier in the discussion, if it is a feature delayed gastric emptying, I think the thing to think about and to exclude is there a pancreatic leak and a small collection in the vicinity, and out of a very low threshold to think about imaging if that was the case, just to know what you're dealing with. But I don't think any other surgical technique or procedure is going to significantly influence the incidence or the prevalence of delayed gastric emptying.
Well taken, sir. Any other comments, or can we move to Kantaria? Dr. Rachel would like to add something to that?
No, I agree. Having been lucky enough to work in Edinburgh with many great pancreatic surgeons, I've concluded that the operative technique, no matter how good it is, people will leak, and it's just supporting them well through that.
Okay, and one other.
So if I have to put it other way, it's by doing a broad jejunostomy, it's not going to prevent your leak. If it has to happen, it will happen.
Point is taken, sir. And before we close, the one last question. I'm sorry, Bojwani, sir, would you like to add something?
No. Oh, I thought you were just about to conclude, and I would just like to quote what my boss used to say, that if you have done a Whipples, and even if the patient is getting pain in the toe, think of a pancreatic leak first and rule it out.
Point is taken, sir. I think we have one quick question to all of you from Dr. S.K. Sharma. Say, in this case, in an absence of an imaging evidence, can we take this as a possible potential case of a postoperative pancreatitis with the exudation of amylase from the surface? He brings into a different dimension, but please share your experience on postoperative pancreatitis.
Again, I'm happy to comment. So the amylase in the drain went up to, I think, just over 4,000, which isn't very high, but I think the picture with postoperative pancreatitis in the early period is more a situation of severe pain. And the other thing that I think points to this was a leak, was the change in the color of the fluid exudate coming out in the drain from what was very serous or serosanguinous to being a dark color. So I think putting those two bits together, I think this is quite clearly a leak. It's something that has to be considered in post-operative period. I didn't mention it as one of my specific complications associated with pancreatectomy, but occlusion of the pancreatic duct in the early post-operative period and pancreatitis in the remnant pancreas is a real feature, and certainly we have seen it, but it doesn't usually present with a change in the color of the drain output. It's more pain and signs and symptoms of pancreatitis.
Besides this, I think if you go strictly by definition, it is POPF.
Point is well taken, sir. I think...
Professor Kanagwil, can I make a statement regarding postoperative pancreatitis? There has been a substantial literature in the last 4-5 years on postoperative post-Whipple's pancreatitis. And that's how we started looking at it. And I can tell you, I have had at least about 4 or 5 such patients where we documented postoperative pancreatitis in a Whipple's on the CT scan postoperatively and on the enzyme levels in the blood. And these were the patients who then converted to kind of an abscess. And there was a paper last year which said that perhaps it is the pancreatitis also postoperatively which contributes to POPF. So it is possible that what we get to see in terms of clinical scenario and imaging finding, when we actually start investigating, we do attribute it to a postoperative pancreatic fistula, but it is possible that some of these patients actually had pancreatitis to begin with, which later on converted to postoperative pancreatic fistula. And in my unit, at this point of time, we very strongly believe that the stent might have to play a role. So for all those people who are using a stent in the pancreatic jejunectomy, which I had been doing for almost about 17 years, and I stopped doing 3 years back, I think there was perhaps a reason for the postoperative pancreatitis to come. And one of our postgraduates is doing his thesis, the PhD research on postoperative pancreatitis after pancreatic jejunectomy. Hopefully, we should be able to share some information with you maybe 2 years later.
I think we have had enough deliberations and all good things have to come to an end. So we have exceeded more than 30 minutes of the proposed time. And I think it is definitely a lot of learning this evening. And I'm sure all of you will agree that both the young ones, Dr. Diana and Dr. Govindra, did justice to this evening. And before that, we had a lovely talk from Professor Parks and Dr. Rachel, Dr. Bojwani, and Dr. Kantaria. It's been phenomenal sharing of knowledge, and I'm sure it would have evoked very keen interest in young surgeons and practicing surgeons as well. Mr. President, would you like to add something before we call a session to the close?
Yeah, it was a very beautiful, lucid presentation, very simple by Professor Park and these two young guys, Diana and Govindraj. They presented so nicely, and both the cases, managed very well. And today's discussion is wonderful. Thank you all.
I think we should be having such bilateral meetings more often, President sir.
Yeah, we are having, sir. We are having frequently
bilateral meetings.
Yeah, we are all bilateral only. Yeah. Usually, every month we have prime time program. I don't know whether you are aware of it.
Yeah, I've been a part of it a couple of times.
Okay. And we are, and this year we are going to, this year Professor Park and many faculties from UK are coming to our national conference.
Yes.
Along with Neil Smart from, I think he is from London. And we are going there to Edinburgh in the month of October again. And a lot of exchange of faculties and lot of research joined together and research activities. All these things we are planning. Many things are happening in IAGES.
Thank you very much, President. I'm sure it's time to close, and we look forward for more active deliberations, which Professor Parks have already promised us that he will look into his calendar, and potential possible collaborations of academics is definitely in the offing. And I personally would like to thank the time shared by Professor Parks, Professor Rachel, Professor Kantaria, Professor Bojwani, and the young ones, Govindraj and Diana. And it's a procedural formality. We request our Honorary Secretary of the IAGES to propose the vote of thanks.
Thank you, Dr. Kanagve. So officially, I would like to thank Professor Parks for his wonderful deliberations on such a difficult topic. And we commonly face those who are doing pancreatic surgery with these two complications, which have been dealt beautifully by the young Diana and Govindraj. And we also thank Dr. Rachel for her kind presence and also sharing her views. Dr. Chetan Kantharia and Dr. Rajesh Bhojwani for deliberating as moderators on this subject. And we thank our president and Kanag Vail for taking prime time. This was the last in this academic year, and hope in the coming year also we'll be doing things more actively. I would like to thank the whole Doc Plus team for have their continuous support for this activity. And we look forward to meet Dr. Parks and many more faculties in next fortnight. So wish you a happy journey. See you, sir, next week. Thank you very much, everybody. Good night.
Good night. Thank you.
Thank you.